Hi everybody, I'm Jeanette Oberg, and I am actually another psychology professor and a department chair here at MSJC, and I am going to be doing your presentation for mood disorders, which is module or chapter 4 in our current textbook. And when we talk about mood, we're really talking about emotions, and so as you learned about in the first module, it's really interesting when we talk about disorders, right? Because we all experience fluctuations and changes in our mood. It's normal for us to experience sadness or maybe even elation. And so what constitutes a disorder? A disorder is when those emotional fluctuations begin to take on a pattern that disrupts our normal functioning and the quality of our lives, either personally, professionally, intimately. And so here we're focusing on, establishing the criteria for a mood disorder as determined by the DSM-5, which is our Diagnostic and Statistical Manual. So let's talk a little bit about mood disorders. We're going to talk, there are a number of different mood disorders. This is just an intro class, right? So we're just dropping some seeds and giving you a general overview. But in reality, the DSM outlines a number of mood disorders. We're going to focus on 2 primary mood disorders for the purposes of this class. We're going to talk about depressive disorders and bipolar disorders. When you talk about depressive disorders, depression is something that many of us are familiar with, and maybe some of us have even experienced. We might have had a depressed day or a depressed mood, but whether or not we actually experience a depressed episode would depend on the DSM criteria and whether or not we meet that criteria. But depressive disorders are applied to people who only experience depression. They don't have any episodes of mania or hypomania. Bipolar disorders experience both depression as well as mania and or hypomania. It's really important to recognize that in both of these types of mood disorders, you also can have periods of regular mood. So that's not to say you're always depressed. You can have a normal mood for a portion of that time. You can have, you can experience joy and other emotions while still experience or meeting the criteria for depression. Same with bipolar. You're not always in a manic state or always in a depressed state. Sometimes you absolutely do have intermittent periods of just a normal mood, okay? So think of these as kind of opposite extremes, where bipolar is more an elevated mood and energy level, and depression is more of a depressed or hindered mood or energy level. But as I mentioned, there are a number of different types of depression. Some are more familiar to us than others. We're going to focus primarily over here on the left end of this spectrum with major depressive disorder, persistent depressive disorder, and bipolar, which is also known as manic depression. And there's 2 different types of bipolar. There's also cyclothymic disorder that we'll talk about a little bit as well. But these other depressions, we aren't necessarily going to go in and discuss thoroughly, but if you take a future abnormal psych class in an upper division when you transfer, you may actually learn more about those disorders in greater detail. So in terms of depression, depressive disorders, there are 2 main types of depressive disorders: major depressive disorder and persistent depressive disorder. Major depressive disorder is where you have a depressed mood, and an episode of depressed mood has to last at least 2 weeks long. And persistent depressive disorder is more of that chronic depression. So we may have a major depressive disorder, and then we pull out of it and we go on about our lives. Now, that does put us at risk of having future episodes of depression. We might very well still meet the diagnostic criteria of depression, but it is something that we can recover from, right? And then we have the potential to relapse in the future. Persistent depressive disorder is chronic. It lasts for at least 2 years in order to meet that diagnostic criteria. Sometimes when you're going to your health doctor, there's a box where you have to check, what your pre-existing conditions are, and sometimes it might appear as dysthymia, but it's currently known as persistent depressive disorder, and it's continuous, it's pervasive. It feels like it's just something we can't escape from, and so that is, it might have more acute, which is more like immediate onset, but it's chronic in terms of its persistence and duration. So let's talk about symptoms of depression. So depression is not just mood. I know we often think of it as our emotions, but it's not just moods. There's physical symptoms, there's behavioral symptoms, and there's cognitive symptoms. And I see the numbers are wrong, so let me fix that. But in any event, mood is referring to your emotion, right? Your affect, and that's your emotional expression. And when you have depression, a mood consists of having a depressed mood for most of the day. That's not to say you can't laugh periodically throughout the day, right? And you might have just a loss of interest in pleasurable activities, which we call anhedonia. There's also physical symptoms. Some of us sleep more, hypersomnia. Some of us sleep less, insomnia, where we have difficulty falling asleep or staying asleep. Some of us gain weight because we eat more. We might engage in comfort foods more. Some of us lose weight and we lose our appetite altogether. So our weight can fluctuate and our appetite and eating can fluctuate, which those two are obviously directly related. We might also have psychomotor disruptions. And by psychomotor, we're talking about movement whenever we're talking about motor, but we're talking about movement related to our psychological state of being, right? So we might have an agitation that manifests itself in tapping, pacing. My brother would shake his knee up and down a lot, right? But just an overall restlessness. So that's like increased or the addition of movement that's reflecting that agitation. There's also retardation in our psychomotor functioning, in that they might be slowed, impaired, and hindered. So we may not be moving as quickly. We might be a little bit more mopey in our movement, slow to get up, slow in our walk, slow in how we just transition from one position to the next. The third category of symptoms is behavioral. So this is really interesting because you gotta focus on like what's normal for you, right? I'm not a really physically active person, which is problematic because it does impact my long-term health and well-being, right? But think about what is decreased activity for your levels. Are you not engaging? Are you not up and active? If you're exercising, if you really aren't motivated and not doing that as much anymore, if you're a dancer and you're not doing that as much anymore. So think about your normal activities, and have you lost that active engagement in your life? Are you not as productive? And that can be work-wise, school-wise, in your home. Maybe you're not completing your tasks and your chores around your home. So whatever responsibilities or duties that you have, are you slowing down in those areas? And then, are you unable to meet, manage, maintain your personal responsibilities, whether they be social responsibilities, or you've made commitments to do things for friends, with friends, or whether they're your school responsibilities and you just don't really have that energy or motivation to get those tasks done, or even at work. And then finally, cognitive symptoms. And cognitive, when we talk about cognitive, we're talking about your thought processes, your thinking, your problem solving, your reasoning. And individuals experiencing depression have very different cognitive mindsets. They might maintain very negative views of themselves, of the world overall. They might look at themselves as not good enough, not worthy, not smart enough, not pretty enough, and it becomes problematic. And they may look at the world from a depressed mindset as well. Often when negative things happen, they blame themselves. They might think it's their fault. It's not that I didn't do well on an exam because it was a hard exam, but I'm stupid. And that's problematic, right? They also struggle to find their own self-worth and self-value. And that's so important in fundamental to so many areas of life. They create this negative feedback loop, unfortunately, where they have these negative thoughts. They attribute everything bad in the world to themselves or to bad outcomes. And what that does is that kind of creates this cycle where that negative thinking creates negative mood. The negative mood perpetuates this negative cycle, and it reinforces that negative thinking, right? Or if they have these negative thoughts and then they have negative experiences, it reinforces it. And so unfortunately, it can become a very vicious cycle, and that makes it really difficult to disrupt. And that's why therapy is so important, to help disrupt those negative thought patterns. They may also have difficulty focusing, concentrating. Attention is a challenge. Memory might actually be a challenge. So they can get easily distracted. It might be hard to sit down and read a book or do an assignment or take an exam. And unfortunately, they also have higher risks of thinking about suicide. Now, it's not uncommon that an individual might think something like, we might say things callously sometimes, like, I wish I was dead. Those, I'm a suicide loss survivor, so I'm particularly sensitive to those types of comments. I'm mindful that sometimes we say things and that doesn't mean we're suicidal, right? But I'm also mindful as a mental health professional that we need to pay attention to those things because those are warning signs. And so when we're engaging in kind of self-harm, self-destructive behavior, or contemplating how the world might be better if we're not in it, those are problematic things. And so we definitely want to get help for ourselves and definitely support our loved ones who might be experiencing those things as well. So let's talk about the diagnostic criteria as outlined by the DSM-5. For major depressive disorder, you have to have a depressive episode or depressed mood, that loss of interest in pleasurable activities, and you have to have at least 5 symptoms across those 4 categories we just discussed. And those symptoms must last for at least a 2-week period. So a depressed episode is defined as these symptoms occurring for a 2-week period or longer. Once those extend beyond 2 years, that might actually qualify you for persistent depressive disorder. So the time frame during which you experience these symptoms is what differentiates between these 2 diagnoses. Additionally, instead of having to have 5 symptoms across 4 categories, for persistent depressive disorders, you have 2 or more symptoms across the 4 categories. You may experience some sort of relief over that 2-year period. You may not be in a very deep depression that whole 2 years, but if you do have, points where you're feeling well, if they last over 2 months, then it no longer meets the diagnostic criteria, right? So typically we have kind of moments, bursts, periods of feeling well, but then we relapse right back into the depression. My mom experiences persistent depressive disorder, and it's been crushing for me. There are moments of joy that I'm able to capture with her, but she does fall right back into that depression. So let's talk a little bit about bipolar. So bipolar is when you fluctuate, and there's periods of mania. And so you have not just the depressed episodes, but you also have manic episodes. Now you can either have manic or hypomanic, and hypomania is like a mild mania. So if we're looking at those as the 2 extremes, depression and mania, Hypomania doesn't have the same extreme expression as does a full manic episode, but it definitely has elevated energy, pressured speech, thought processes, just not as extreme. So it might be more subtle. We might think of it as being energetic for a particular day or feeling really good and productive, but it's not our normal sense of wellness. It's a little bit elevated, and we'll talk more because, we often think like excessively happy, excessively sad. That's not the extent of mania, so we'll talk more about the characteristics of mania in just a bit. So with bipolar 1, you typically have you have at least one manic episode, so it meets the diagnostic criteria for mania. Bipolar 2, it can just be hypomania. Now, bipolar 1, you might have periods of hypomania, but you are going to experience a full manic episode. And bipolar 2, you do not have manic episodes. If you have manic episodes, it would be classified as bipolar 1. So let's talk about mania. Mania, so my dad had bipolar. He was diagnosed with bipolar 1. He had periods where, like, I'd call him and he'd say, oh, I started making birdhouses. And, like, within 2 days, he made, like, 26 birdhouses. And I was like, dude, have you talked to your doctor recently, right? When's the last time you were in therapy? When's the last time you went to a group session? Because when he's that productive, he's not sleeping, he's so intent and focused, and I'm like, oh, those are red flags for me, right? He also became excessively irritated. Now, my dad in general wasn't an irritable person, but when he became irritable, very short-tempered, and he was really like just a more kind of harsh person, and that wasn't my dad's regular personality. And so I knew that was one of the signs of a manic episode. He could experience elation and happiness, excessively so, but it was more of his energy level. He was actually more angry and irritable than he was necessarily happy. But he would go into these kind of wild laughing sprees, which were a little scary, disconcerting for us. Also, high-risk behavior. They might drive really fast. They might engage in risky sexual behavior, gambling, credit card usage, financial irresponsibly spending money. They also might quickly fluctuate. So you're not really even sure where it came from, but their mood often shifts, and it's kind of like out of nowhere. Very grandiose self-esteem, sometimes delusional self-esteem. My dad often thought he was Jesus Christ, and that's when we really knew that he needed intervention, and that often led to hospitalizations. But they can think they're indestructible. They can think that they're powerful and all-knowing, and have excessive confidence too. And that actually, it can be dangerous because it opens up opportunity for increased risk-taking. Additionally, the activity level, as I mentioned, that energy level, oh my gosh, it's almost like being around someone that's on speed, on meth, where they're, or coke. So pay attention to that. They don't sleep a lot, don't even necessarily get that tired feeling or desire to sleep. Their speech is very interesting. It can be very pressured. So they're talking like they're going, almost like those TV commercials where they're giving all the disclosures at the end. But sometimes it can be very, like, those are monotone in terms of their emotional expression, but these might be more intense. And they're really committed to what they're saying. And sometimes they go off on these tangents that you just don't understand what they're saying, because their thoughts and ideas are all over the place. And that's what we call flight of ideas. When they have these racing thoughts and ideas and they just can't keep up and they're trying to get them all out. So their conversations may seem very incoherent. They're hard to follow. In terms of hypomania, these are more mild. So what I just described, but kind of a mild, definitely elevated from our kind of normal everyday mood and expression, but they have 4 days, at least 4 days of kind of elevated but not extreme symptoms that were just described. Cyclothymic disorder, as I mentioned, it's hypomania with mild depression. So both bipolar 1 and bipolar 2 often experience significantly depressed moods. But cyclothymic, it moderates more in the hypomania and the mild depression. It doesn't dip into the deep depression, and it doesn't get up to the extreme mania, okay? You have that fluctuation for 2 or more years. Again, you might have those intermittent periods where you feel well and comfortable and normal. Individuals who experience cyclothymic disorder may actually, it may lead to the diagnosis of bipolar 1 or 2. When we talk about epidemiology, we're talking about the occurrence. So what are the patterns that we're seeing? What's the prevalence rates? So we'll primarily focus on U.S. prevalence, and we'll primarily focus on looking at gender differences. I will say, sadly, research does not really do a lot of data tracking for individuals outside of the binary gender identity, which is inherently problematic. I will tell you that LGBTQ individuals do have higher risk of experiencing depression. That's not necessarily because of any biological reasons, but it's often because of the social and cultural factors where they experience more stigma, bias, and they don't get the same type of social support that individuals who are cisgender experience. And so I do want to just throw that disclaimer out there. And this book doesn't really get into talking about those differences in occurrence and rates across different gender, sexual, and orientations. And so we need to talk about that as well. So again, major depression has about 7% of the people in the U.S. experience it. Overall, though, over our lifetime, the prevalence rate is anywhere between 12 to 21%. So it's much higher. So about 1 in 5 people. Sometimes you have studies that show 1 in 4 people might experience depression at any time over their lifetime. But at any given time, about 7% are currently experiencing symptoms that meet the criteria for major depression. Persistent depressive disorder is much lower. That's kind of good news, right? Because it indicates that that fewer people have that chronic long-term. Sadly, college level is the point at which you're at the greatest risk of experiencing depression. I'm a developmentalist, so we really talk about all the changes that are happening at that age. And females are significantly more likely than males to experience depression. We have different theories as to why that occurs, and we'll talk about those later. For bipolar, it's even a lower prevalence, so there's a lower risk. Only 0.6% of people in the U.S. for bipolar 1 and 0.8%, so less than 1% for both bipolar 1 and bipolar 2. We don't see a whole lot of gender differences in the rates in terms of epidemiology, but we do see bipolar 2 rates for bipolar 1. But we do see bipolar 2 as being more common in women. When you talk about rapid cycling, so that's when the moods change quickly. So you might be in mania for a while, and then you might be in a normal mood and depression for a while. Of course, depression quite often follows a manic episode. So they go from mania to depression, but they might come back into normal mood and then go back up into mania. Rapid cycling is when those changes occur a lot faster. And so 80 to 90% of rapid cycling occurs in women. So there's gender differences in the timing of those mood changes, the mood fluctuations. No gender differences for bipolar 1, but yes for bipolar 2. So let's talk about suicidality. First of all, I want to introduce you to language, right? So we historically have talked about committing suicide, and we've kind of moved away from that language. So we commit crimes. And although suicide might officially be a crime in some languages, it really treats it more as a behavioral problem rather than a mental health problem. And we need to really remove the stigma associated with mental health and recognize that it's just one other aspect of our overall health and well-being. It directly impacts physical health, and physical health directly impacts our mental health and well-being. So when we talk about suicidality or we talk about suicidal ideations, we don't talk about someone as committing suicide. They may have completed suicide, or they may have attempted suicide. And we also are really mindful of those who've experienced suicide loss. So I'm a suicide loss survivor. I have lost my brother to suicide when I was 19 and he was 23, and it impacted me in very profound ways and shaped the woman I am today and much of the work and advocacy that I do today. So when you experience depression or bipolar in particular, you are at greater risk of experiencing suicidal ideations and completing suicide. And so we need to pay attention to individuals when they are diagnosed with depression or bipolar disorder. Depressed males are at greater risk, and I would say suicide completions are higher among males, and that's often because of the type or the methods that are used. And so we'll talk about that later on in the course. We do know that bipolar puts individuals at greater risk, so significantly more likely than the general public to attempt suicide. 33% of individuals with bipolar disorder are at risk of attempting or completing suicide. And when we talk about all the suicides, this is in the US, 25% of them are likely connected back to bipolar disorder. So it's hugely problematic, and you're most at risk of completing suicide or attempting suicide in the manic state, not the depressed state. Often in the depressed state, we don't necessarily have the energy or the motivation to follow through on those thoughts, but in a manic state we do. And that's why we have to be careful with antidepressants, because we're in a depressed state, so we're not always motivated to action, right? We might have the thoughts, but we're not motivated to action. But when we're taking antidepressants, they're giving us that energy. That's why the risk of suicide increases when you've recently been prescribed with antidepressants. So that period from depression to getting better, that's still a risk period when our energy levels are up, but our thought processes are still not stable yet. So just watch out for your loved ones. Know the signs. There are signs and warning signs to alert us that help is needed. Comorbidity means the co-occurrence. So it's not uncommon, particularly with mental health issues, that things co-occur. Like diabetes often co-occurs with obesity, right? Same thing with mental health issues. So depressive disorders often co-occur with substance use and anxiety. It's not uncommon for an individual diagnosed with anxiety to also be diagnosed with depression, or substance use to also be diagnosed with depression. In fact, substance use might be used as a self-medication, right? We're trying to find ways to escape that unhealthy emotional state. So 75% of individuals who have major depressive disorder are also diagnosed or meet diagnostic criteria for another disorder. So it doesn't mean that you're super extra sick. It means that some of the symptoms overlap, right? Depression can be the byproduct of other mental health conditions, and so know that they're very related, right? Bipolar disorders are very commonly present with anxiety, disruptive impulse control disorders, and conduct disorder. So ADHD individuals, I'm going to say it's not uncommon that individuals with bipolar also have ADHD, but not all ADHD individuals have bipolar. So I hope that makes sense. Again, substance use, in fact, in the manic state, that substance use can be one of the risk factors and the red flags, because it might be extreme abusive relationships with alcohol and various drugs. So I don't want to say most, 50% or half of the individuals who have bipolar also meet a diagnostic criteria for substance use disorder, and commonly it's alcohol abuse. My dad was an alcoholic, and he used alcohol as a means of self-medicating himself all those years, and we did not come to understand that it was bipolar until his 40s. So it was a little bit later in life. Individuals who have both do have a higher risk of suicide, so those are the individuals we really need to pay special attention to. All of them warrant special attention, right? And then, of course, it is possible to have not just 2 or more disorders, but 3 or more disorders. And 60% of individuals with bipolar 2 actually have 3 or more conditions. So etiology is looking at the causes. What are the causes of these disorders? And in psychology, the reality is it depends, right? A biologist or a biopsychologist would explain it differently than maybe a psychoanalytic perspective. And so we are mindful that there are probably a combination of causes. It's not just one of these, it's a combination, right? So in biology, we focus on genes, biochemistry, brain structures. Genetics do play a role. So we study what's called behavioral genetics in psychology, and we statistically compare rates that are experienced in the general population compared to rates among families where the diagnoses are present. And we know there's a 30% increase in relatives. So you have a 30% increased risk of experiencing depression or bipolar if you have a relative that has depression or bipolar. The closer, if it's a first degree relative, so they're in your immediate family, your risk is higher. If they're a second degree relative or someone in your extended family, your risk is lower. Only 10% of the general population experiences these things, but 30% of individuals when there's a relative diagnosed. So we know that genetics must play a role because biological family members have more like genetic similarities than with the general population. We also look at twin studies, and we compare just regular siblings, fraternal twins, and your fraternal twins are 2 separate eggs, 2 separate sperm. They do not share 100% of the same genes, and so that actually is where we share the same genetic composition as a regular sibling, but we did share the same fetal environment, right? We did share the same in utero experience, and so that could account for some of the differences. Identical twins came from the same egg, and that egg splits apart, so they're called monozygotic twins, and they share 100% of the same genetic makeup at conception and at birth. Now, interestingly enough, what we know about gene and environment, our environment can activate genetic changes. So when they pass away, they may not share the same 100% genetic structure, but definitely when they're born, they do. We call that epigenetics, how our environment influences our genetic structure. That being said, when identical twins have a higher concordance rate, so the rate of occurrence is higher among identical twins, then we know that genetics must play a larger role. And for depression, identical twins have a 46% concordance rate. In other words, 46% of the time one identical twin has depression, 46% of the time the other twin has it too. For fraternal twins, it's only a 20% concordance rate. So when one fraternal twin has it, 20% of the time the other twin has it too. We have identified the 5-HTT gene that might actually be a factor in depression due to its relationship to serotonin. And we know that bipolar has a stronger concordance rate among identical twins than fraternal twins. And so bipolar actually might have more evidence for a genetic influence than depression. Biochemically, the two neurotransmitters that are most involved in depression and bipolar are norepinephrine and serotonin. Usually we have low levels of norepinephrine and low levels of serotonin for depression, but with mania, it's low levels of serotonin and high levels of norepinephrine. So that norepinephrine kind of depends. If it's low, it's depression. If it's high, it actually can induce manic episodes. So other things to think about from a biological standpoint include our endocrine system, so our glandular system, right? And our endocrine system and our nervous system regulate our psychological health and well-being. Our endocrine system produces cortisol through our adrenal glands, and high levels of cortisol are associated with depression. Melatonin is also related to depression, and melatonin is actually the hormone that kind of activates sleep. And so too high of melatonin levels may contribute to sleeping too much, and not enough may not allow you to sleep, both of which can be related to depression. Then there's also brain anatomy, so our prefrontal cortex, our hippocampus, and our amygdala are all focus areas in the brain that might be related to depression. Specifically, we may not be getting the same blood flow. The hippocampus is smaller now. We don't know which comes first, right? Is it that these brain structures are contributing to the disorder, or is it that the disorder is actually impacting our brain structure? We don't know, right? It can be either. And so more research needs to be done. It'd be different if we did a brain scan and we did PET scans and monitored everybody on a regular basis, and then we could see if once they manifested a disorder, how that changed, but we don't do that. So it's hard for us to know which comes first. Bipolar, the basal ganglia is involved, the cerebellum is involved, which interestingly enough, the cerebellum is largely involved in your motor functioning as well too. And so that might actually speak to some of the agitation and the energy levels. And then of course the amygdala as well. Cognitively, learned helplessness is a challenge. And this has been well researched. It started in looking at studying dogs who got shocked in cages, and initially they would jump and yelp, but over time when the shocking continued, they just laid there and took it. And unfortunately, individuals that experience depression kind of demonstrate some of that same mindset. They just accept that this is kind of their way of life, and they learn not to expect positive things and outcomes, and that becomes problematic. Attributional styles, when we're talking about attributions, we're talking about what are we attributing causal things to, or how are we explaining, what's our rationale in explaining why something's happening. And so some of us have very internal attributional styles, some of us have very external attributional styles, but internal, stable, and global influence is when we're looking at a negative attribution, we think everything's our fault. We think it's constantly our fault, and we think that that everything's negative all the time. So that kind of negativity in that attributional style contributes to depression. We also need to understand, like, how are we interpreting daily events? And how much time are we spending really ruminating on those events? When we recognize that some things are outside of our control and we're willing to let go of those things and offer ourselves self-compassion and grace, then it allows us to be healthier. But when we're constantly kind of ruminating on those things, it becomes problematic, right? And when we think that everything bad that happens is our fault, that becomes very problematic as well. So a positive attributional style, we recognize that we're not to blame for everything. We recognize that things happen. We recognize that there's other outside influences and environmental influences that affect things. And so we're not as likely to generalize everything and to take on that blame. So Aaron Beck is one of the most famous individuals as a theorist and as a clinician to help us understand depression. Not only understand some of the underlying thought processes, but he also developed cognitive behavioral therapy, which actually has shown a significant efficacy or effectiveness in treating depression. So these maladaptive attitudes, he talked about this cognitive triad where depression occurs from our thoughts, our emotions, and our behaviors all together, right? But the maladaptive attitudes, when we have these negative attitudes about us, about the people in our lives, about the world in general, when we kind of generalize and take that negativity global, and it's inaccurate. Like I might say, I'm dumb, instead of, hey, I just didn't study hard enough, or I didn't put in the time and energy. Or we say, oh, I suck at math. Or maybe you just haven't had someone explain it to you in a constructive way for how you process information, right? So we have these inaccurate attitudes, we kind of generalize so they're global, and consequently we may isolate ourselves emotionally and even physically. So how we interpret those negative thought processes affect how we interpret. They influence our emotions, they influence our behaviors, they influence how we interpret just a small event in our daily lives, how we kind of attribute things to ourselves, and how we interpret our hope for our future, and it's problematic. We also engage in errors in thinking, so we catastrophize, kind of a Chicken Little, the sky is falling. Instead of looking at it as one test, it's, I'm going to fail. I'm going to fail psych, I'm going to fail out of school, that kind of thing. We also jump to conclusions. We make assumptions that aren't healthy. We interpret things negatively, so those assumptions are also often negative, I should say. And again, we overgeneralize. We have these automatic thoughts where our consciousness is just constantly filled with negative thinking, and that's problematic. We need to recognize when we're in those thought patterns and stop them, and then try to reframe and restructure. And all of these things can contribute to depression, a sense of inadequacy and helplessness. So we definitely want to work to counter those things. So the behavioral explanation, when we talk about behavioral perspective in psychology, we're really talking about environmental influences. So you may have heard about the debate between nature and nurture. Biological explanations are focusing 100% on nature. Behavioral explanations are often focusing 100% on nurture. What's happening in our environment? So we look at classical conditioning and Pavlov and just those unconscious associations. And then we also look at Skinner and what we call operant conditioning for rewards and punishments. And then we also look at social learning theory and what's been modeled to us. And that is from Bandura. So from a behavioral standpoint with depression, we do look at rewards and punishment. And sadly, when you're not, when you have a negative experience, that reinforces your negative thoughts, right? And your ideologies. When you are withdrawing from those activities, you're now reducing your opportunity for positive rewards, positive interactions. And so unfortunately, that contributes to you reducing your constructive, healthy coping behaviors, and you might just stop trying altogether and actually gain that learned helplessness that we talked about earlier. And keep in mind that when we talk about etiology, so because these are the presumed causes, it might directly influence what we think the treatment should be, right? So we'll talk about that when we get to the treatment. So sociocultural causes might be family social perspectives where we may not have strong social support system. I'm not a believer that we come from quote unquote broken homes. The idea of a broken home is a myth and misconception, in that families come in all different shapes and sizes and structures. And so it's important to recognize that not one is broken, they're just different. However, it is important to have people around you, whether those are your actual legal family or whether those are loved ones that you've chosen as your family. It doesn't matter, right? It's that social support. Separated and divorced individuals may actually lose access to their social support system, and consequently they're three times more likely to experience depression. Depression can contribute to divorce, and divorce can contribute to depression. It goes both ways. Depression can lead to interpersonal conflict. It can lead to communication barriers and challenges. It can reduce intimacy, sexual and emotional, with you and your partner. But also those things can contribute to depression. So again, we don't know which comes first, right? It's the chicken and the egg debate. So keep that in mind. From a multicultural perspective, we recognize that our cultures matter, and many of our cultures, there's stigma, it's alive and well, and we have negative views about mental health. Some cultures deny the existence or validity of mental health. Some cultures want to pray your mental illness away, and they don't recognize the biochemical processes involved in mental health functioning. And so it's problematic, right? And recognize that we all express things in different ways. We all have different behavioral expression, different energy levels. Some cultures are individualistic versus collectivist. So pursuing your own joys and pleasures might be problematic in some cultures. So consequently, the way depression is expressed across cultures might be very different. In non-Western cultures, they might report more physical symptoms and fewer cognitive symptoms. In Latinx and Mediterranean cultures, they might talk more about their nerves, or they might report more headaches. So expect those differences that might occur. There's another diagnostic manual. It's the ICD. It's the International Classification of Diseases, and that is often used in other disorders and diseases. That is used in other cultures and countries and to diagnose mental health issues. In the U.S., we use the DSM. And then within the U.S., there are still cross-cultural differences, right? And we actually, we don't seem to have as many differences in, who's going to actually experience depression, but there are huge differences in who seeks help, who actually gets treatment. Caucasians or European individuals are more likely to seek help. And 80% of the time, that help successfully addresses the symptoms for them. However, those rates decline for communities of color. And so we really want to work at reducing the stigma in communities of color so that they can have access to greater access and greater quality of care. So sociocultural causal factors, it's interesting that women experience depression at higher rates than men. And so why? Artifact theory suggests that our diagnostic processes might actually have gender bias built in, or the way in which we describe them are more consistent with socially acceptable ways for women to express their emotions and behaviors and not men. Men actually are more likely to manifest depression in terms of anger and irritability than they are sadness. And so those are things to think about. Hasn't been as much empirical evidence to support that theory, but the logic is there. Hormone theory, talking about our estrogen, progesterone levels, that menstrual cycle, and how that might trigger depression, is also something that's been proposed. Life stress theory, sadly, women are more likely to experience chronic stress. We take on that second shift. We carry more responsibility for the family responsibility, the household, even when we're working. And we actually are in lower paying jobs quite often. And there's a wage gap even when we're in the same job as our male counterparts. We have higher risks of unemployment, poverty, abuse. And so all of those compound our life stress and therefore may trigger depression. There's also the whole gender role theory, where we are socialized to express ourselves differently, to care for people differently. We don't have as much agency as men, and that might put more responsibility on us in terms of the roles and responsibilities that we have. It might also contribute to the fact that we're not valued as much in society, and so that could impact our risk for depression. Rumination theory, which has been well supported by the research, is we actually analyze things, and sometimes overanalyze things as women, but we ruminate. We think about things more and more and more, and so we might have a negative experience and process that negative experience over and over again in our minds, and that could make us more vulnerable to depression. So let's talk a little bit about treatment. So when we're talking about psychopharmacological, we're talking about drug therapy, right? Sometimes we call it psychotropic medication, but it's all drug therapy, okay? So antidepressants are fairly commonly used. They're used not just for depression, but for anxiety and for a whole host of other physical conditions. They're easy to access. It's easy to write a prescription, often just your regular doctor does without any kind of therapeutic consultation, which I find to be a little problematic. That convenience might hinder people from actually seeking therapy, and research shows that drugs in combination with therapy are the most effective approach. So SSRIs, so if you ever take a psychobiology class or even anatomy and physiology, and you learn about the neuron and you learn about in those synapses we release neurotransmitters, and there's a reuptake process, so the other neurons around that release only have a certain amount of time before we actually have these systems that vacuum up that unused neurotransmitter and actually recycle it, repackage it, and recycle it for future release. And so SSRIs stop that reuptake process of serotonin. So it gives the other neurons a longer time to process the serotonin. And as we discussed, serotonin is one of the neurotransmitters involved in depression. SSRIs are very common because they have very little side effects. They're effective with just small dosages. And when they do have side effects, you can be nauseous, you can have a reduced sex drive, and sometimes sleep difficulties. So it's really important to recognize that we all kind of process things differently. We all metabolize medication differently. And so it's important to know your body, your symptoms. And when you're getting any kind of prescription, pay attention to how that changes. Or if you have a loved one that's on these medications or just starting these medications, know that you have to kind of find the right drug for you. SSRIs are the most common, so they often try those first. But if they don't work, don't give up, right? Just try to find a new dosage that might work for you or a new drug that might work for you. So keeping logs and communicating with a therapist or the psychiatrist or the doctor that's managing the medication is really important. Therapists don't prescribe medication, but they can work with your psychiatrist or your medical doctor to adjust medication as needed. Tricyclics, they're called tricyclics because of their molecular shape. They also block the reuptake. They have more extensive side effects, and so that's why they're not as common, because the side effects are more common, and people report discomfort with those side effects, and some of them can be dangerous. Tachycardia in particular, that's when you have a rapid heart rate. It can be dangerous. Your MOI inhibitors, those actually, unfortunately, can cause huge risk for hypertension, which puts you at risk of a heart attack. And so the reuptake process is one method where it kind of vacuums up and repackages and recycles, but then there's also the monoamine oxidase, which is released, which kind of breaks down the neurotransmitter. And MAOIs should be, I'm actually thinking I wrote that wrong, so I'll have to fix that. Anyway, those actually reduce that enzyme from breaking down the norepinephrine, serotonin, and dopamine. Again, the side effects are problematic, and diet is really important when you're on this particular treatment. So, okay. As I mentioned, cognitive behavioral therapy has been demonstrated to be an effective approach. It addresses the thought processes, how those influence your emotions and your behavior. So the therapist tries to intervene and disrupt those negative thought processes, because obviously they have a direct impact on what we do, but also be mindful that our activities and our behaviors impact what we think and what we feel too. So they're all related to one another. What you want to do is you want to kind of be aware of your thoughts, understand what you're thinking. So they might include journaling, right? They might have you monitor your thoughts more closely so you can be intentional about identifying when you're engaging in unhealthy or faulty thinking, and then they will actually challenge your faulty assumptions. So therapists will help you see kind of how there's maybe not logic in your thought processes, and they will give you alternative ways, healthier, constructive perspectives to replace that maladaptive thinking. They might include some behavioral interventions, which include planning activities with you, identifying things that you like to do, scheduling those things into your life, assigning you homework assignments, and teaching you more effective coping mechanisms when you are experiencing those negative thinking patterns. And so here's some 4 phases of cognitive behavioral therapy. First, they want you to get engaged in healthy, pleasurable activities. So they may get you to select things, identify them, plan them out, and engage, and then report back in future sessions. They're going to actually educate you about your negative thinking and teach you about how it impacts your emotions and your behavior. And they're going to teach you to identify those thoughts, and they're going to then teach you how to reframe those thoughts and change those thoughts. So it's a process, right? First, we become aware of these negative patterns. Then we learn about how these negative patterns impact our overall health and functioning. Then we learn how to identify them in the moment, and then we learn strategies how to replace them with healthier coping approaches. So other depression psychotherapies, by psycho we mean, what we typically think of as therapy, psychological therapy. Behavioral activation where we're getting up and we're getting involved and we're getting engaged. So we're focusing on our behaviors, our activities. What is it that we're doing? And we want to, again, be mindful of those things, identify those things. If we're just laying in bed, sometimes we wait for the mood and the motivation to get out of bed, and others would argue, well, get out of bed, and then that will impact your mood, right? Instead of waiting for mood to lead to the getting out of bed can lead to a positive change in mood. Interpersonal therapy, where we are seeing a therapist in counseling, and we're recognizing it is a medical condition. If we could please adopt this, move away from this false conception that we're weak, we're somehow less capable because we experience depression. No, we're human. We're human. It's no different than diabetes, right? It's not our fault. Often it is connected to life events. So interpersonal therapy helps you process those events. I experienced depression after I went through my divorce. And so most definitely processing my divorce with a therapist was healthy for me. Also, I'm cognizant that when I am experiencing depression, or like my mom experiencing depression, it absolutely impacts her relationships. And so unfortunately she closes us off. So when she does experience stressful life events, she doesn't have that support around her because she's isolated herself from us. And so that's problematic. And we need to find healthier strategies. And that involves even being around her when she's depressed, when she doesn't want us around. We have to kind of force ourselves on her a little bit. Multimodal treatment is using multiple approaches. And it's not uncommon, as I mentioned earlier, medication in combination with therapy is effective. Sometimes they can be done simultaneously or concurrently. Sometimes you do one and then the other, maybe start medication and then go to therapy. Sometimes, we might start small doses and start therapy quite often and then step that up. But combination approaches are usually more effective. For bipolar, therapy alone is not sufficient. Bipolar quite often depends on some sort of drug intervention as well. Mood stabilizers are the most common. Lithium and Depakote are the most common mood stabilizers. They do have long-term implications on your physical health. They do have side effects, so it is important you're actively monitoring your liver levels, working with a medical doctor and a psychiatrist to monitor their impact on you. Sometimes they do those in combination with antidepressants, not always. Of course, you need to work out your individual plan with your individual medical providers. And then psychological therapy in combination with drug therapy is often very helpful with bipolar individuals. Often the mood stabilizers help to stabilize the mania, and then they can work with therapy to address some of those other thought processes involved in the depressive episodes. But again, psychotherapy alone is not sufficient. Medication is almost always necessary with bipolar, and a lot of your therapy is focused on teaching people to maintain their medication, because often when they're feeling better, they stop taking the meds. And the meds have a therapeutic dosage, right? So they have to be in your bloodstream at a certain level in order to be effective. And if we stop taking them or aren't taking them as prescribed, it's problematic. Psychological therapy can also help with problem-solving skills, social skills, coping mechanisms. So it's really important to include both. In terms of outcomes, depression, 80% of individuals that seek treatment report improved outcomes and improved health and well-being. So they're highly effective. Medication is good for short-term relief, but psychotherapy is really what helps to provide that long-term stability. So you have greater risks of relapse if you had these episodes at earlier ages, have severe symptoms, and you experience suicidal ideation. But don't think of it as a failure if you've relapsed. Recognize that that's part of the condition. That's a feature of the condition. And so also be sensitive to your loved ones who experience depression and recognize they get better. They're not broken when they have a relapse. They're still that strong, wonderful, empowered human being that you knew when they were at ideal functioning. And they just need love and support through those challenging episodes, okay? And then bipolar, again, lithium tends to be a really good mood stabilizer. Decades went by before my dad had a recurring episode. But again, he was really super good about maintaining his medication and working with his doctors. Not everybody is that great. And so if you have a loved one with bipolar, advocate for them, look out for them, watch out for them, and support them as best as you can. Okay, and so I hope this was helpful in better understanding. Recognize that we are learning so that we can maybe identify symptoms within ourselves, so we can identify symptoms within others, and from a supportive standpoint, so we can offer support, love, compassion. But we are not here to diagnose others. This is one class and a very broad overview. There's much greater detail that you'll find in the DSM and in subsequent coursework if you're going to be a psychology major. But I'm hoping that you're going to gain this knowledge just to offer you a greater sense of empathy and compassion for those individuals experiencing depression or bipolar disorder, or for those individuals supporting a loved one with bipolar or depression. And I hope that you can practice self-compassion with yourself and compassion with others. Best of luck to you. Bye-bye.